is assumed to be the same. So the cost here, when multiple drugs are being compared, the least expensive should be chosen. Then when we are carrying out CBA, that's the cost-benefit analysis, the outcome is being measured in monetary units. Both outcome and cost are measured in monetary units. So this one gives an advantage in that different alternatives can be compared when they have different outcomes. And the alternative that gives the most benefit, the benefit that outweighs the cost, should be chosen. Then thirdly, we have the CEA, as a cost effectiveness analysis. Here, the outcome is being measured in natural units. The blood pressure, blood sugar, cholesterol lowered, cases cured, life year gain. That's how the outcome is being measured. So it determines and compares the extra cost for each added unit of benefit. For each added unit of benefit, for each milligram per DL of blood sugar reduction, the extra cost that alternative gives. Then lastly, we have the CUA, that's the cost utility analysis. This takes into consideration the patient preferences, and the outcome is being measured using the quality adjusted life year for the patient. You can see from this table, this is an example of how the analysis are being carried out. The CMA, cost minimization analysis. When you look down, the last line, you see the antibiotic effectiveness is 90% for drug A and 90% for drug B. This shows that the outcome is the same. So now we are left with the costs. Compare the cost. The subtotal for the cost for drug A is 500, while the subtotal for drug B is 400 naira. So the one with the least cost, that's the drug B, will be chosen for that particular treatment. Then the next one, the CBA, that's the cost-benefit analysis. Assuming we are comparing drugs for the treatment of urinary tract infection, drug A and drug B. So for the cost, it's still the same. We have 500 naira for drug A and 500 naira for drug B. But because cost-benefit analysis is being measured in, the outcome is being measured in monetary terms, the benefits here, we have the days at work that the patient was able to work as a result of taking this particular drug. When it's being converted to the monetary terms, we have 1,000 naira for drug A and 1,000 naira for drug B. But the extra months of life that the drug will give the patient, we have 2,000 naira for drug A and 3,000 naira for drug B. So totaling it, we have for drug A, 3,000 naira as benefit and 4,000 naira as benefit for drug B. To calculate the cost-benefit analysis, the benefit to cost ratio would be done. That's dividing the benefits by the cost. So for drug A here, we have 3,000 divided by 500. It gives us a ratio of 6:1. For drug B, we have the benefits being 4,000 divided by the cost being 400. So the ratio gives us 10:1. So that's the way, one of the ways that cost-benefit analysis can be calculated. Then we can also use the net benefit by subtracting the cost from the benefit. For drug A, the cost is 500, while the benefit is 3,000. So when we subtract the cost from the benefit, that's 3,000 minus 500, we have 2,005. For drug B, the cost is 400 and the benefit is assumed to be 4,000. So when we subtract 4,000 from the benefit, that's 400, that's the cost from the benefit, which is 4,000, we have 3,600. So the one with the highest ratio would be chosen. Then going further, we have the cost effectiveness analysis. This particular cost effectiveness grid is comparing about 9 drugs. And you can see from the grid, the one with red color, that's the D, G, and F, will be more cost effective because D has lower cost and same effectiveness. Lower cost with the current, let's say the current standard gold treatment that is being used compared to a new drug that you want to recommend. So The new drug now has lower cost and same effectiveness. So that's cost effective, it can be chosen, is desirable. Then the G, it has lower cost and higher effectiveness. Lower cost and higher effectiveness, that one too is desirable. Then drug H has same cost but higher effectiveness. So D, G, and H can be accepted to be cost effective. But from this table, you can see B. B has same cost and lower effectiveness compared to what you're using. Same cost but lower effectiveness. Why would you choose something of lower effectiveness when it will still give you the same cost? So it's not desirable. Then we have C, higher cost, lower effectiveness, not desirable. Then we have F, higher cost and same effectiveness. That too is not desirable. So all the ones in green, the B, C, and F, they are not desirable. Then we are left with A, E, and I. E has same cost and same effectiveness. If the clinician or the economist will be choosing E, then other things will be taken into consideration. Probably the one you're using is a parenterally administered drug, and the new one is an oral one. So other things will be taken into consideration before considering if E, the new drug, should be added to your formulary or not. Then we find out that most, like A has lower cost, lower effectiveness, and I has higher cost, higher effectiveness. But you find out that most new drugs that you might consider adding to your formulary or your essential medicine list, most of them come with higher costs. So to calculate this, other methods of calculating cost effectiveness analysis should be employed, as we can see in this next slide. On the first row, we have the current preferred medication. That's the medication that is being used. Then we have the new medication. Let's say we are comparing simvastatin and rosuvastatin in the management of cholesterol. On the second row, we have the cost for 1 year of the current preferred medication being 1,000, while the new drug, let's say rosuvastatin, has 1,000. The cost is for 1 year of taking that particular alternative gives 1,005. So in a year, the outcome after using simvastatin, that's the current preferred medication, we have 25 milligram per dl of cholesterol being lowered, while the new medication lower the lower density lipoprotein by 30 milligram per dl. If the result is being presented like it is in this second row, then it is referred to as cost-consequence analysis. But to calculate further, that's the cost effectiveness ratio, would divide the cost of using that particular drug for 1 year by the outcome. That's 1,000 divided by 25 will give 40 milligram per dl for the current preferred medication. Then for the new medication, we divide the cost, that's 1,500 divided by the outcome, the value for the lower density lipoprotein, and that gives 5 milligram per dl. But now when you are considering if a drug, you want to compare, because most of the time we compare, we don't just want to identify the cost per the value that each marginal cost will give, but we want to compare the effectiveness of the new medication to the current preferred one. So that to do that, the incremental cost marginal reduction in lower density lipoprotein will be done, and that's incremental cost effectiveness ratio should be done, and that's determined by calculating the difference in costs and dividing it by the difference in the outcome. The difference in cost here is 1,005 minus 1,000 divided by the difference in the outcome. That's 30 milligram per dl minus 25 milligram per dl to give 100 naira per milligram per dl. That's 100 naira for every milligram per dl in the cholesterol new agent being used. Then lastly, we have the cost utility analysis. The cost utility analysis, like I said earlier, takes into consideration the patient preferences, and it is measured in quality adjusted life years. After calculating the cost for drug A, we still have 500, and for drug B, we have 400. But the utilities now, the outcome, the consequences of using this drug, it gives extra years of life. That's the quantity of life it adds to the patient. For drug A, we have 2.22, and for drug B, we have 1.6. Then the quality of life index. The quality of life index that the patient gets from taking drug A, we have 0.33, and from drug B, we have 0.441. After multiplying this, the quality adjusted life years for drug A gives 0.73, and for drug B, we have 0.66. So the cost to utility ratio, we get that by dividing the cost divided by utility. The cost for drug A, 500, divided by utility is 0.73. We have 685 for drug A. And for drug B, the cost is 400. The quality adjusted life years is 0.66. When that is divided, we have 0.0606 naira per extra quality of life extended to the patient. So here, the least expensive one would be chosen. So all these analyses, they have their advantages and disadvantages, and that would help to choose, to determine which one particular to use for your analysis. The CMA, that's the cost minimization analysis. Since it's assumed that all the outcomes are equivalent, it can only be used when outcomes are assumed to be equivalent, when outcomes are assumed to be the same. But the advantage is that it is simple, and from what I showed earlier, the one with the least cost can easily be chosen. Example is the brand versus generic. When the brand and generic gives the same efficacy, then we'd rather go for the generics rather than choosing the brand that is more expensive. Then we have the cost-benefit analysis. That one measures the cost and the outcome in monetary terms. So different interventions can be measured, even if they have different outcomes. That's an advantage it has. And especially when one intervention can only be implemented, when the outcome is converted into monetary terms, then the one that gives the most benefit would be chosen. But the disadvantage is that there are some outcomes that may not be easy to monetize. So for those, then different approaches may be used to put a monetary value on them. We have the human capital approach, and we have the willingness to pay. For the human capital approach, let's say an immunization is being given to children to prevent a particular disease, let's say meningitis. They collect immunization to prevent meningitis. So the human capital approach assumes that the productivity of that person can be monetized. So when such is monetized and the person is not sick, the value on that productivity is what is assumed to be the outcome. And but the disadvantage is that whatever the patient is earning, whatever level of productivity, whatever monetary terms is attached to the person's productivity, does not really mean that the person would give that value to the society or to the society. Then another way it can be measured is the willingness to pay. How much is the patient willing to pay to prevent that particular illness? How much is the patient willing to pay to get immunized to prevent developing COVID-19 infection? So if the patient is willing to pay, does the patient really have the money to pay this? So all this is difficult to put monetary terms on them, and that might make cost-benefit analysis difficult to measure. Then we have the cost effectiveness analysis. That's the third one. Decision makers use this to identify the preferred choice among possible alternatives. Like you can see, when we did the cost effectiveness grid, there are about 9 drugs were compared. So the most preferred can easily be seen and identified. But the subjectivity as to whether the added benefit is what the added cost is a disadvantage. like we saw in that calculation, 100 milligram per DL, 100 naira per milligram per DL reduction in lower density lipoprotein. Is it really worth it? The added benefit, is it worth the added cost? So that one is subjective and is a disadvantage for this CEA, cost effectiveness analysis. Then lastly, we have the CUA as a cost utility analysis. The different types of outcome, either the quality or quantity of life extended to the patient, can be measured by one unit. That's the quality adjusted life year. And here the least cost is chosen. But you find out that it's difficult to get an accurate quality adjusted life year value, because 1 year in good health state is not equal to another year to the same year, 1 year in a diseased health state. So to perform all this analysis, the economist or the clinician will have to follow 10 steps to make the results reproducible and very objective and systematically done. The first step is to define the problem. What do you want to do? What analysis do you want to carry out? Do you want to identify a new, develop a new protocol, or do you want to recommend if a new drug should be added to a formulary or your essential medicine list? You define the problem to be solved first. Then the second thing is to determine the study perspective. From whose perspective are you carrying out your study? Is it from the patient's perspective? Is it from the hospital's perspective? Is it from the insurance company's perspective? That will determine the cost to be identified. So the third step here is to determine the specific treatment alternatives and outcome. By alternatives, I mean, let's say we want to treat urinary tract infection. We want to determine the alternatives that can be used. Is it the sulfur drug? Is it the fluoroquinolone? Do we have a new drug that is being promoted? So you identify different alternatives. In identifying this alternative, you choose the one that is being used. We don't choose outdated ones, because it's to be a waste of time and resources to choose our outdated one, or the ones that are not really effective. So we choose probably the one that is being used. The next one, though, may be more expensive, and you compare it to a new one that you want to introduce. Then you identify the outcome from these different alternatives. When the outcomes are identified, then you can easily select the pharmacoeconomic method to use, because like I said, the outcome is the pharmacoeconomic analysis is categorized based on the outcome identified. So after identifying the cost, alternatives, and the outcome, you measure the input, that's the cost, or the resources that the alternative would need. You measure the inputs and the outcome from these different alternatives. So number 6, you identify the resources needed to conduct the analysis. The resources needed, I mean, if the study is a retrospective one, do you have data that you will use? Do you have access to the data, medical literature, medical record, probably clinical trials that you want to consult to make your decision? Then if it's a prospective study, do we have the time, the resources, the budget within the allocated time to conduct this analysis? Then you establish the probabilities for the outcome of the treatment alternative. By probabilities, I mean the chances of success, failure, probabilities of developing side effects, possible probabilities of adherence to medication. There's a need to establish all these probabilities for different alternatives that maybe the clinicians or might have chosen. Then you construct a decision tree. When you identify your alternative, you identify different outcomes that can come from this alternative. Then it will be easy to construct a decision tree, as we will see later in the course of our discussion. Then step 9, conduct a sensitivity analysis. After establishing our probabilities for success, let's say there's 95% probability for success when you use drug A. Sensitivity analysis means varying these probabilities. If it shows 95%, you might want to say, okay, if it's not 95%, it could be 90%. It should be varied on a relevant range of values, maybe 90%, maybe even 10%, so that the study can be valid and robust enough. Then the last 10, after conducting this study, there's a need to present the results to policymakers, probably to prescribers, to people that would the result would make impact on. So these 10 steps can also be employed, because most of the time you find out that an institution or a facility might not be able to carry out this analysis on their own. They might have to review literature to make their decisions. So to make their decision, if they are reviewing literature, this 10 steps can also be employed. Then if presenting the result, these steps can also be employed to present the steps, the results systematically. Steps in decision analysis. The decision analysis helps to visualize the pharmacoeconomic analysis. It helps to see it graphically, and easily a preferred alternative can be chosen. So step 1 in decision analysis is to specify the decision, what you want to do. Is it that you want to add to a formulary a new drug or not? Or you want to develop a new one? You specify your specific decision. If you're adding a new drug, you specify how long the new drug will be taking, both alternatives, how long the drug will be taking, for what duration of time. Then step 2, specify different alternatives that can be used for that particular intervention that you want to make. Different alternatives should be identified and specified. Then step 3, specify possible outcomes and probabilities from each of those alternatives that has been chosen. Step 4, you draw the decision analysis structure. We will see that one later in the slide in the course of our discussion. Then you perform your calculations. Calculation can easily be performed with different computer softwares these days to make the analysis easy. Then step 6, there's always a need to conduct a sensitivity analysis. That's to vary the cost estimate, because we are assuming. And I didn't say something about the cost. If it's a retrospective study, the current cost should be used. Then if it's a prospective one that is projected to take place more than a year or so, then the cost should be discounted because of the present value of money, time value of money. It should be varied. So sensitivity analysis should be carried out based on different probabilities. Probability for success, probability for developing ADR. All these should be varied to get a valid result. So this is an example of a decision tree. Okay. Hello? Hello?
Yes.
Yes.
Okay.
It's very clear.
Okay.
Continue.
Okay.
Yes.
Oh, sorry. So this is an example of a decision tree. We have, on the first, we are managing UTI, urinary tract infection. Then we have various alternatives, the choices that we might have. We have drug A and drug B. Drug A and drug B. For drug A, we can see success on the upper side and failure. So that's probability for success. We have 90% probability for success and 5% probability for failure. On the decision tree, there are different nodes. The first node here, that's the choice node. That's the arrow from the UTI. It is represented by a square. That's the choice node. But when we have a chance node, that's probability for success or failure, a chance, then it is depicted by a circle. That's after the drug A. There's a circle there at that node. Then we have the terminal node. That's giving us the terminal, the outcome of interest. So on the decision 3, for all the alternatives that you might have chosen, this has to be done. Is it what percentage do we have for success, or percentage do you have for failure? Then after having the success, probability of developing a side effect, 5% here. Probability of not developing side effect at all, 95%. And the cost for each of these outcomes is being calculated. So after calculating all this, then the ratio can be determined. If you want to do, if it's like this one now, the urinary tract infection, we're more interested in the cured rate. So that would be natural units, measuring natural units, and it will be cost effectiveness analysis. So after determining the cost here, then the cost effectiveness ratio can be calculated. So in application now, we can say that pharmacoeconomics will assist in decision making, especially when the resources are limited and you have just an option of choosing maybe a service to be carried out or not. Imagine if there's a decision to make if a patient should undergo transplant, renal transplant, those that have end-stage renal disease, or the patient should remain on dialysis. So when you do your pharmacoeconomic analysis, you'll be able to see systematically and objectively what decision should be taken. Then it helps to assess the value of a new agent or a new service. If you are introducing a new drug to your formulary, you will see the outcome, probably based on your own study, based on the treasures that you have critiqued. You'll be able to make your decision. 3, it helps in formulary decision making. It helps in determining the price in the pharmaceutical industry because they will measure all the inputs also. Then it helps in drug policy decision, treatment guidelines. Then it helps insurance companies in determining what products, what service they want to reimburse or not. So in conclusion, I would say pharmacoeconomics is one of the competency skills of pharmacists that has to be promoted and emphasized. It has to be promoted to ensure quality care is being delivered within the limited available resources. Thank you for listening.
Thank you so much. That's a very, very beautiful presentation, well detailed. In fact, tonight we have all become a pharmacoeconomist now. You've been able to show us the link between pharmacy and economics. It's a very wonderful presentation. Now we move on to comments, questions. So do we have hands up? For those who want to comment, please raise up your hand. Pharmacist Ibrahim Yaya. Ibrahim Yaya.
Yeah. Good evening, all.
Good evening, sir.
Good evening, sir.
That was a wonderful presentation, and I would like to start by congratulating the presenter for delivering a well-articulated presentation, especially on pharmacoeconomics. I have one question, then comment and a contribution as well. Let me start with my question. And when you are discussing about cost-benefit analysis, I want you to shed more light. There was a place that you were discussing about the CBA ratio. The drug A has the ratio was 6:1, and drug B was 10:1.
Okay,
I would like if you can shed more light on which drug are we going to choose when we have the CBA analysis as 6:1 and 10:1. That's my question. Then my second question is based on COVID-19. I don't know, what can you say during the first wave of COVID-19, the Nigerian Center for Disease Control, NCDC, wanted to introduce remdesivir for management of COVID patient in Nigeria. And at that time, I was among those that tried to discourage wire remdesivir because of the costs, since we have been managing with chloroquine, azithromycin, and vitamin C. Why remdesivir? So I don't know. What can you say about the cost effectiveness of using new agent like remdesivir with our common drug that we were managing it? And also, if we are going to compare the cost of managing with the chloroquine and co with the cost of bringing vaccine to Nigeria, what can you
Hello?
Yeah, the noise was interrupted. So in a nutshell, okay, the cost of using a vaccine, this COVID-19 vaccine, and the
Yes.
cost of management using our common drugs here, especially chloroquine and vitamin C.
Yes.
Thank you so much for the presentation.
Thank you, sir, for your question. So I will take the first question first. You said the best benefits, CBA, cost-benefit analysis. The benefits to cost ratio 6:1, and compared to drug B, which is 10:1. So the one that gives the highest ratio would be chosen. The one with the highest ratio will be chosen. If the ratio, because the benefit is the benefit is the one we are dividing with now. So if it's lower, that means the new drug or the benefit, there's no, the new drug does not have any benefit. You can see that another way to calculate it that I mentioned was subtracting the benefit from the cost, subtracting the cost from the benefit, sorry. When you subtract the cost from the benefit and it gives you a negative, that means it's not desirable. So the one that gives the highest ratio or the highest benefit is the option to be chosen. Now to the drugs for the management of COVID-19. Remdesivir was obviously very, very expensive, and it will have been out of reach to a lot of population in Nigeria. So if we're considering that, even if you, like I said, that the steps to conduct this analysis, we listed 10. If we have to review the literatures, different clinical trials that were being done, some would even tell you that the remdesivir was more like a placebo than being very effective. So why would you go for something that is still dilly-dallying and all that? Why not go for something that we're sure of the outcome and is giving us desired result? So in considering all this outcome, you know, even the different, we have a different population. What is being the race, comparing the genomics, the difference in races and all that, what is obtains in other climes, we might want to try it in our own population before it will be really accepted in our population. So we might not really have to do it,
Yes.
have to carry out the clinical trial among us, because most of these drugs, they are even like repurposed. There are drugs that have been in existence that have been repurposed for this purpose. Probably they've been used for Ebola and all that. So when we consider the outcome from the use of this drug, probably in different climes, in different races and all that, we can make our decision, draw our own decision tree, and see the outcome and see if it's worth it to go for it or not.
Okay. Okay. Thank you.
Yes, ma'am.
Can we move on to the next person? I can ask Pharmacist Orok to unmute himself. Edidiong
Yeah.
Orok. Okay.
Yeah.
Thank you.
Yeah. Wonderful presentation there. Thank you very much for your presentation. Uh, what I have to say is actually about more like a comment, and a question is more of both. Okay. Um, I know that to calculate cost effectiveness ratio, to carry out a cost effectiveness analysis, that there are some maybe some applications that can help one carry it out effectively. I know one that is called, is it the T-Trip app? I don't know if the presenter knows anything about that. Why I'm saying this is I'm actually doing something related to it. I'm doing my PhD in clinical pharmacy and pharmacy administration, and the study I'm doing is kind of like related to something like this, where I have to calculate the cost effectiveness to do a cost effectiveness analysis. So I don't know if the presenter knows any other software that can be
Yeah.
used, because I saw the schematic where she was talking about nodes and all that. I know that diagram can easily be done using an app. I know there's an app that can help do that, make that the
I think we lost him, but I think the question is captured.
Yeah. I want to ask that, is it me? Okay, then let me move on to Pharmacist Alima Adedeji.
Hello, ma.
Okay.
Good
Hello.
evening, ma.
Good evening. You're welcome, ma'am.
Good evening. Thank you very much to the organizers and the presenter. It's very wonderful. Thank you so much. I have three questions. Number one, I noticed that most pharmacoeconomic analysis studies focuses on disease control management, drug alternatives. Okay, maybe like, for example, cost of performing pharmacoeconomics on the choice of monitoring ADR or not, as to not monitor ADR, like that, focuses more on that. And then there are limited studies on interventional methods. For example, maybe like looking at telemedicine versus hospital visits, pharmacoeconomic analysis on that, studies in that realm is very rare. Or maybe like looking at maybe active surveillance to passive surveillance. I've tried to lay my hands trying to check, because I'm doing similar study for my PhD, and it's been difficult. I don't know if the presenter can kindly share with us some specific references, that dealt on focuses more on interventional methods, even making a decision tree for such methods, maybe for example active surveillance, or maybe we should focus on passive surveillance in pharmacovigilance. Decision tree for that has been very difficult for me. I don't know if you can guide us through. Then the second question is, during the pharmacoeconomic evaluation, can we say that, okay, we have options? Do we stick to one method, maybe just cost minimization analysis, or we can use maybe like one or more methods? Say we use the cost minimization, we use cost effectiveness. I don't know if you get that my question. Or we can only use one pharmacoeconomic method to to evaluate. Then if there are apps for calculating, I think you mentioned that, kindly also share with us, and I'll be very grateful. Thank you very much.
Okay, ma. Can I take the question now?
You can. Then I also want to say maybe she will have to put her email address too, because some of it she may not be able to really talk about it now, especially the first part of the question where she was asking for references. The ones you can do, please take it down.
Okay.
Thank you.
Okay,
Thank
so
you.
our question is almost similar to the question the previous speakers spoke about. There's different probably application that can be used to conduct this pharmacoeconomic analysis. Based on time and limited space to make this presentation, I was unable to put in different software or websites that can be explored for this. But we have a study material and it's been posted on the platform. So I believe the study material on pharmacoeconomics can be explored. And from it, we can get a lot of other probably websites or apps that can be explored for different methods, different study that or analysis that we might want to carry out. There's the pharmacoeconomic analysis is not limited to pharmacotherapy, it's not limited to drugs. It can be used for services, it can be used for surgery, it can be used for any medical intervention or any particular intervention, because all you are measuring is you are identifying your inputs, you are measuring and you are comparing. So the inputs can come in any form. The inputs can come in any form to be measured. It doesn't have to be pharmacotherapy. Then you asked about if only one method can be used to conduct pharmacoeconomics. No, different methods, different pharmacoeconomic analysis can be carried out on a particular study. You might want to do CBA, cost-benefit analysis, because you are converting your outcome to monetary terms. You might still want to do the same study if the outcome can be measured in natural units like the blood pressure, the blood sugar measurement of the patient. So you can do cost-benefit analysis and as well as cost-effectiveness analysis on the same study, but you now carry out different analysis. Then lastly, you asked about the apps. I guess the apps. So like I said earlier, I didn't really explore that, but I believe you can get it. The study material really gave us a lot of different apps and websites that can be explored. Thank you.
Thank you too.
Thank you very
It's really work in progress. I give kudos to Dr. Ibrahim and the brains behind this presentation, because now tonight we've had 3 pharmacists already who said they are working on pharmacoeconomics. I think from there you can collaborate and take it higher. You want other areas to look into, then people can come together and do that. Then I'll move on to the next person that the hand is up, Dr. Ademola Sulaiman. Can you unmute yourself? Dr. Ademola Sulaiman, are you there?
Yes, I am here.
Please unmute. Yes. Okay.
Good evening.
Welcome.
Good evening, sir.
Yeah, I want to commend the efforts of the presenter.
Thank you, sir.
She has done a great job to it. Before I forget, I also saw Professor Suleiman Ismail, but I don't know whether he has disappeared. I want to say that people should hold on to him. He has a lot of papers on the pharmacoeconomics, especially those people that are doing PhD. So they can run after him, hold his shirt, and they get some vital information from him.
Yeah,
Be that as it may, I also want to say that the speaker talked about ratio 10:1, 6:1. I want to say that the administrators, many of them, they don't understand the mathematics or they don't like it. So I actually want her to explain the interpretation of why do you want to choose 10:1 as against 6:1 or otherwise in a statement. Because saying that the one with higher ratio is better than the one of the lower ratio may actually not be understandable to a layman in the real sense of it. My worry and the question in relation to pharmacoeconomics has always been how to validate the parameters when we are comparing. And I don't know whether there are methods in which we can use to validate parameters, especially when we have parameters that are categorical. Let me give you an instance. There is a study that we carried out on the family planning methods, assessment of family planning methods. And we found that there are A and there are B. The A, which are unemployed, and B, which are employed. The factors that are significant to the two are actually not the same. To A, they can walk 4 kilometers to go and collect the free family planning methods, while B, that are employed, would not mind paying for it as long as they're not going to walk that 4 kilometers. How do you validate such parameters to have a common base for you to compare the best method for the two? Thank you, madam.
Sorry, sir, I didn't get the last question, but your first question, talking about the benefit to cost ratio, the ratio 10:1 and 6:1. When we have 10:1 and 6:1, we are comparing benefits to cost. So the one with the highest benefit that will give more benefit or will consider to be more cost effective is the one with the higher ratio. And that will be more desirable compared to the one with the lower ratio. I hope that answers the question. But the second one, sorry, I got lost along the way. I didn't get it.
I'm talking about validations of the parameters. For instance,
okay.
For instance, do you get it now?
Yes, I think so. The parameters, it may be very difficult to measure some. Like I said, the quality adjusted life year, comparing the quality of life extended to the patient, the quantity of life extended to the patient, or the cost benefit analysis, that it might be difficult to measure the outcome, to place monetary terms on some outcome. So it might be very difficult, and those are where estimates or probabilities come in. And the analysis is not very perfect in a way, but it's just a way to carry out the analysis in an objective and systematic way. So whatever the clinicians or the economists seems okay with to use to conduct the analysis.
Okay.
Sorry, let me have an addendum to it, because there was a paper somebody presented, and what actually it did was to make use of statistical analysis, statistical parameters, finding the significance of the various parameters, and they're using the p-values to actually look at which one is significant, which one is not significant, and which one has a p-value that is close to 0.05 or that is far from 0. So comparing the two, knowing the p-values of all those parameters, you can say A is more significant than the B, B is more than the C is more than the Y, E is not significant at all. So that is the area E was able to use to put those parameters that are actually subjective or are not having the same base.
Outcome. Thank you, sir.
I'll move on to the next person. I have been raising up the hand for some time. Dr. Mrs. Felicia Williams, ma. If you are still there, ma, can you please unmute yourself?
Yeah, thank you so much. I want to join others in thanking the pharmacists. Ayodeji,
Yes,
Olani,
ma'am.
for a
Thank you,
very
ma'am.
calm, poised presentation. It was
Thank you, ma'am.
very beautiful. Somehow, I didn't get the explanation you gave on the decision tree for the treatment of UTI, especially the aspect that has to do with side effects. We
Okay.
have side effects, success, and the failure. What is the conclusion? Then the point that pharmacist Ademola was making is that for policymakers, for decision makers, they may not understand the conclusion you are reaching. So sometimes it is good to put it in black and white. Treatment A or medication A is preferred because of this ratio. So you help them to reach that conclusion or to accept that conclusion if you put it in a simple, clear term. So if you can take us back to that decision tree for UTI, to be appreciated. Thank you.
Okay, ma. Do I share my screen again?
To be appreciated.
Yes, can you bring up the slide? She will shortly. Sorry. The decision tree. That's like what?
Okay.
Yeah.
I'm on
Okay.
it. Okay.
Thank you. That's fast.
So we have the drug A.
Can you put it in presentation mode? Slideshow.
Okay. Okay, is it better now?
Yeah, better.
Okay. So we have the drug A. It has two probabilities or chances. We have the probability for success, which is 95%, or probability for failure, which is 5%. But if we're considering the probability, the chance of having a success, a 95% success, is the success with side effect or without side effect? If it's with side effect, then the cost of managing that side effect will be taken into consideration. If it's without side effect, then that one will have no added cost to it. And we can see at the end of the tree, that's the terminal node. You can see 170, that's the one with side effect, and 120, the one without side effect. So to manage the side effects, we have an extra $50 to manage the side effects. That's the first one. But when there's no side effect with the sources, then it's just 120. The extra cost of managing side effects is not included. So probability for failure now, we have 5%. 5% of developing failure when you use drug A. So, but even when there's failure, because it's a drug, there's still probability of developing side effects or no side effect. So we have 5%. That's the third line there now, 5% of developing side effects. And you can still see that the total cost at the end of the day is still 170 because the cost of the drug and the cost of managing side effects is constant. So it's still 170. But the cost of when there's failure and there's no side effect, that's 90%, 95%, sorry. And the cost is 120 because you are not managing side effects. It's just the cost of the drug. So all these are inputs, calculating the costs. So after calculating the cost, then we'll now go to the benefits to calculate the ratio or the effectiveness of the drug.
So based on this, what is the decision between drug A and B?
Well, this is just calculating. It's not, this particular decision tree is not conclusive because it's just a tree showing different alternatives and the costs. We have not calculated the pharmacoeconomics. We have not done the pharmacoeconomic analysis on it. It still extends. I didn't go into that. After determining the cost and the cost of the probabilities for each one, then if we're going to, like this one now, we're calculating the cost effectiveness ratio. So if we are going to do the cost effectiveness analysis, we're going to subtract the difference in costs for drug A and drug B and divide it by the difference in the efficacy. The efficacy for drug A is 95%, while the efficacy for drug B is 85%. So the difference there is 10. So we divide the cost. The cost of drug A, 120. Let's say like having where we're coming from. Drug A has always been 500, drug B 400. So the difference in that 100 divided by the difference in their efficacy, 10, and that will give you 10 to ratio 1 or something like that.
But from what you have just said, we didn't take into consideration the side effects.
No, the side effect is part of the probabilities. It must have been calculated, and to calculate it, you multiply the probabilities by the cost, and that will give you the cost to use for your analysis.
Okay, thank you.
It's a bit complex. If I go into it, then it will take a longer time.
Now we have
but
to.
there are computer softwares even to calculate all this.
Okay, thank you. Let me move on. We have two people raising up their hands. After taking them, we'll have to take the closing remarks and run for them. Yaya, still there? Can you please unmute yourself?
Yeah. Thank you very much, Ma, for second opportunity. I want to also appreciate from Ayodeji, and I want to say I'm happy to hear that we have about 3 pharmacists who are working on pharmacoeconomics, and I want to advise strongly that this lecture is not just enough to discuss about pharmacoeconomics. There are sites that you can become certified on economic evaluation. One of the major sites is University of Washington. They normally offers 10 to 11, I think it's 11 weeks certification course on economic evaluation. I will encourage all pharmacists to try and join and offer this course, because this is an area that has created opportunity for us as pharmacists to really work on. So I would strongly advise, and the course might be coming up maybe in July 2021, because it was done in 2020 around June, July, yeah. So our advice, if we can try as much as possible to register with the site, University of Washington, Department of Global Health. Thank you very much for the wonderful presentation once again. Thank you.
Okay, maybe you can put it later. You can put the information later on the groups so that people will be able to get it to them.
Okay.
Thank you. Is that all, sir?
That's all.
Okay, thank you very much for that contribution. Thank you very much. I move on to the, I think I have 2 people still raising up their hands. Yeah, okay, Dr. Ejiro, please. Yeah, the last.
Thank you very much. Good evening, all. I want to thank the presenter for a wonderful job. He obviously has a grip on the topic. Like Dr. Williams noticed, while the presenter was asking the question, the presenter answering her question, it was becoming more complex, and the presenter stated that the calculations is a little bit complex. And I agree with her perfectly. I was so impressed with her mode of presentation. I remember during the course of my master's, I was supervised by Professor Waka, who happened to be a frontline pharmacoeconomist. And one of my colleagues that did his work on pharmacoeconomics, by the time he was doing his presentation, it was like bamboozling everybody, because the complexity in the calculations and assumptions was something else. For people like us, we didn't just bother. We leave it to the professionals, those who have passion for it, like the presenter, to specialize in that. Because, like you will notice, in calculating the cost of the adverse effect or the side effect, for the three she presented, it made it look very simple. But I remember you have to take into consideration man-hour losses, the cost of going to the hospital to manage, to get to treat the side effect and all of that. In our current situation, my greatest worry is these costs are not stable, and they are not getting an average cost to determine these values, to pick place on these values for competition. I think it's a challenge to us, but I believe we'll get there someday. So for pharmacists who are interested in pharmacoeconomics, embrace it to a large extent, so that when the time is ripe, we are not caught unawares. Because a major problem I also see, while it is very wonderful in decision making, we have a situation where the DRF or the drugs entering the drug formularies or drug being stocked by the facility is not a function of scientific analysis. It's based on who knows who and who wants who to bring items in. So all of that affects us in a way, but just we will not use that as an excuse. We need to be ready when the time is ripe for pharmacists who are pharmacoeconomists to do their thing. So once again, thank you very much to the presenter. And like I put on the chat, those who are doing their PhD should please try to align with Professor Waka, because he's a front liner on this.
Okay, thank you, sir, for that contribution. We have to start to do the closing formality. I will first start by thanking the presenter. She likes the word. When she finished, I was like to clap. I was very impressed by the ease with which she accepted to present, because when they gave us the group, I first saw the topic, I was like, pharmacoeconomics. Upon all the topics that they've been giving people, interesting topics, pharmacoeconomics, I was like, where are we going to start from? But by the time we read through the manual and she started everything, we were able to come up with this, what we have tonight. I thank you most sincerely, and I have to tell you, Professor Awodele was here. I think he's still here. He has said you should consider taking your PhD in pharmacoeconomics. So let me say congratulations. So go and register for that now. Let me recognize some other people that are the Chief Publicity Officer is still here, Dr. Akimbile, Dr. Ademola Sulaiman from all the way from Uganda, our mommy, Dr. Felicia Williams. We thank you for staying through. Dr. Then there is, I don't know, maybe Dr. Professor Ismail Yunusa. Somebody wrote something about him in the chat. They said for those that want to do their PhD, that they should contact him. That is a consultant to Novartis, and you said, and he's working on pharmacoeconomics. Then, okay, that's Professor Waka Anthony of Uniben. So maybe after this, those people interested in it, they should find a way of reaching out. We can put it on the group later. All on the closing. Are you still here, sir? So kindly unmute yourself. Dr. Sulaiman, are you there?
Yes.
If you are, okay. Thank you.
Yes, I'm there. In the name of Almighty Allah, the beneficent and merciful, We thank Allah for the real opportunity He has given us to be alive, to be awake, and be available. We pray that all the knowledge that we have acquired will be to the beneficial of us, our profession, and the humanity at large. We also pray for all the pharmacists in Nigeria and the entire world. We pray for our patients, and we pray for our dear country, Nigeria. We pray for peace in Nigeria, and then we pray for our family. May God continue to be with us and be with everyone. May He increase us in knowledge, in piety. We also pray for those that have gone, that God should overlook their shortcomings. He should forgive them their sins. We also remember that one day it will be our turn. We pray that whenever we want to go, we should go as believers, and we should sleep in the grave as believers, and be in the companies of the righteous one on the day of accountability. Subhana rabbika rabbil izzati amma yasifun. Wassalamu ala mursalin. Alhamdulillah rabbil alamin.
Amen.
Thank you, Dr. Ibrahim. Thank you, and we are grateful for whatever the network is very good tonight. So I guess we are lucky. Yes. Yes.
Thank you very much, sir. Thank you for this opportunity.
So it's bye for this year. We'll meet next year by God's grace. Okay, good night, everyone.
Good night.
Good night.
Bye-bye.